Yep. Okay, great. Thanks. And thank you for inviting me to the offer to tell you a few things that we've done here at Stollery. And special thanks to Shannon for the title that you see there of de-implementing. So I wanted to talk a little bit about how we've been using some of our evidence to both implement our best practices and de-implement some of these contraindicated and very entrenched practices. So we do have a pediatric pain committee here at the Stollery, and you did see that I put there, get a committee, grown. But we've had a pain committee here for well over 20 years. It's gone through several revamps, depending on what our focus is. And one of the best things, I've been on it since 2000, so 14, 15 years I've been on it. One of the things that we've done is really try to keep it brief. So we only have 5 one-hour meetings a year. Samina's on it, Shannon's on it. We have an interdisciplinary membership that crosses the care spectrum, crosses disciplines, and most importantly, we have families, 4 or 5 families that are active participants. Of course, they can't all come to the meetings, but certainly we do try to use technology now to get them attend as well. We try to have very productive meetings with a purpose and agenda, minutes circulated in advance so that we don't have to waste time on that at the meeting, so that we really can move forward and get things done. We do re-examine the terms of reference in our membership regularly, so on an annual basis we look at it again and go, do we have people at the table who want to be at the table? I invite people, and my colleagues on the line can share that I just go grab people and go, hey guys, why don't you come on the pain committee? This is the sort of thing that we like to do, and I think you'd be really valuable to be on the committee with us. One of the things that we've learned over the many years is that it's really okay to rotate our membership and give people a break off the committee at some point in time. So certainly, especially with the physicians, we've had people come on, stay on for a few years, go off, try something else, and always invite them to come back. Likewise with our families, every 2 years I ask them, do you want to stay on? Do you want to go to an ad hoc? What would you like to do? And it seems to be quite productive. So it's all about passion, and it's all about having those people around you that are passionate about what you're doing as well. I can't emphasize enough the point of having strong leadership and having leaders who care and have a lot of enthusiasm. And I think my colleagues could probably say that I'm a little bit of an Energizer bunny and do have a lot of enthusiasm for what it is we do. I can't stress enough the importance of having our senior leadership involved, actively involved. Now, they don't sit on the actual committee because, of course, they're far too busy, but I've met on several occasions with the executive director of the Stollery to ensure that we do have that support from leadership from a financial point of view, but also from recruitment point of view, from sharing the message, and from making sure that pain stays at the forefront here at the Stollery. Again, direct involvement from those who do. So having those people who are actually caring for the kids rather than those of us, well, I do care for the kids, but certainly from a manager point of view, making sure that we have the ability of our frontline staff to be attending. And as I said, including our family. Our philosophy is that we're always thinking QI with research in the back of our mind. So we're looking at projects that we can do and then can share as we go forward from a knowledge translation point of view. So I'm going to talk about a couple of projects that we tackled as a group over the last couple of years. And one of the things that we look at is what do we need to change, what needs to change. And so I'm going to use that example of codeine, as we're all aware that there's been several publications of how codeine is dangerous for young children, and in fact should not be given to children under the age of 12. But also, more importantly, it's probably not an effective drug for up to a third of the population. They just don't have the enzyme to be able to convert it. So we needed to get rid of it out of our institution. So a decision was made a few years ago to get rid of codeine out of our children's hospital, as well as at Alberta Children's Hospital, and we worked with a committee across the province to do that. We picked an implementation date. We picked a committee of a whole group of us who were really dedicated to making this change effective. We picked our implementation date, which luck would have it was about 3 days before Health Canada warning came out saying do not give this to under the age of 12. So we kind of lucked out there. But then when we went, okay, how are we going to do this? We know we need to do this. So we picked multiple intervention strategies. One of my favorite, and I still wear it, is my No Coding for Kids button that we provided for lanyards for all of the frontline staff working at the hospital. And I can tell you that one was really successful because it was in everybody's face. And so parents then started to question, well, why am I getting a prescription for coding when you're wearing a button that says no coding? The other one that we did was we put a big poster on the front page. We're still paper-based charts here, so every chart in the Stollery had this poster with a no coding for kids on the front of every chart so that it was in everybody's face. And in fact, again, there was a parent who saw it and then questioned the surgeon why they were giving them a coding prescription when there was a big stop sign on the front of the chart. We held face-to-face in-service talks on all of the units at times that were convenient for them to really get to those frontline caregivers. Because even though nurses don't prescribe, nurses administer, and nurses are there 24/7. So we really targeted the nursing group, and we found that was really successful in helping change our prescribers' routes. We did email blitzes to prescribers from department chiefs so that it came from the right person, because an email from me isn't going to get read by a surgeon necessarily, but an email from the chief of surgery or the chief of pediatrics does get read. And Samina can talk a little bit about how they did that. She actually even walked around and handed people the triplicate form so that they could get their triplicate. We also provided people with the evidence of what they could administer instead. So we talked about maximizing out our ibuprofen, our NSAIDs, talked about maximizing out our Tylenol, and gave them a specific dosage for oral morphine with information on how to administer that instead for those kids that needed it for moderate to severe pain. We went from, I can't remember, 900 doses the month before to 0 after we implemented. So we did do a successful change with it. Pick what you can change. So an example that we're looking at right now is our use of topical local anesthetics prior to pokes. So what we've done is we tracked the use of our topical local anesthetics through our medication dispense on our Pyxis for inpatient units and found that it was abysmal how much of that drug we were taking out. We knew it. We heard it from people that the creams just weren't getting applied. And one of our big areas that we needed to work on was with our lab. So we struck a committee again. Hello? Oh, hello? Sorry. Hello? Oh, somebody else just joined. Sorry. Okay. We involved the lab in every step of the way. We are now developing these posters that you see here. I'm sorry, that's just a draft. That's why it says do not copy. I'm still working on the pictures and stuff. It's going to go above every bed in the Stollery and including the emergency rooms, asking parents, reminding them that they can ask for the numbing cream with information about when it should go on there and for what kind of pokes we're talking about. And we've got, I think, 6 or 7 kids that we've taken photos of to be able to put them on the posters. We're also encouraging staff to write the date, the time that they put the Maxilene on the little white spot of the Tegaderm so that we can know that it's on long enough. And hopefully that's going to greatly improve our use of topical local anesthetics. Pick workable projects. We do a pediatric pain handbook that has been around for probably at least 20 years, well, at least 15 years. We revise it every few years. And so what we really did was we hugely revamped it last time in 2012, reduced it to the need to know, and put the nice to know more online. It's about 34 pages. It's pocket size. We have printed copies that have been paid for by a grant to be able to hand these out to all the staff. And so every staff member who cares for kids at the Stollery gets handed one of these to have in their pocket, so that they can pull it out and just reference what are our policies. We addressed procedural pain, acute pain, chronic pain, palliative pain. We have a section for neonatal. We go through assessment, and then we go through the 3 Ps for all of those. So physical therapies, pharmacological therapies, and psychological therapies. It's been quite successful. I wish we could do a little bit more analysis on it, but it's kind of tough data to get. But certainly the feedback from everyone is that this really is quite a handy book to have. So my personal philosophy when I'm working with kids with pain, because as we all know, it sometimes gets overwhelming. You can't fix everything. So if you're not familiar, I always think of the starfish, that, you know, I can't save all the starfish, but if at least I can throw a few of those back into the ocean, we are making a difference. And that helps us all go forward. And that's it.